therapy for that. It gets worse, and then she kind of has the next level of concern where she has what we call cord signal change, and it's basically thought to be from like venous congestion, where there's inflammation in the spinal cord. I think you could probably do it from the front. I could probably do it from the front, but when I see that cord signal change there, I just worry with that swelling and whether I'm going to get adequate decompression. It may end up that I do something from the front and then it buys her a surgery from the back, and so you can get a much better decompression of all the nerves in the spinal cord by doing it from the back. So I agree with Dr. Love. I'm in agreement with that. The same levels too, C3 to T1, and not necessarily decompressing to T1, but fusing to T1, putting screws in at T1 and decompressing from C3 to 7. This isn't something that physical therapy is going to really help with, or injections or anything like that. And what I will do is I'm going to message Eric Mitchell, and I just want to know that he's okay from a cardiac perspective, that you'd be okay for this surgery, and then we'll get the ball rolling and get it approved by insurance, and get going on it. Recovery for that is probably about 8 weeks or so, meaning like surgical recovery, like wearing a brace, not doing a lot of heavy lifting, bending, twisting, taking it easy. Neurologic recovery from this, anytime I see that cord signal change on there where that's inflammation in the spinal cord, I tell patients you can get recovery of your nerves up to 2 years from the time of surgery. It just takes a little longer when you see that. I would expect you to notice a positive difference, even a small positive difference, probably shortly after having the surgery. I mean, the spinal cord likes to be not pressed, and so, and then the risk of surgery are small, but not 0%. Anytime we make an incision, we can have infection, we can have bleeding. Anytime we put screws in patients' bones, they can loosen, fracture, pull out. Anytime I'm working around the spinal cord or nerves, I'm super careful. I mean, we actually examine you in surgery by giving you little shocks, kind of like the nerve studies that Dr. McCabe did. I do that in surgery too, so that I know that if I'm doing something that's not jiving with your nervous system, I know, and I change course. But there's small risk of numbness, tingling, pain, weakness, paralysis. People can have strokes from surgery, and people can die from surgery. And again, those risks are really low. The higher risk would be to not do anything, and so
the consequences of not doing anything.
Not doing anything, you'll tend to get worse until basically you're if you're just like, I don't want surgery, Dr. Binglis, I'm going to come back and see you. No, I'm just saying.
Oh, yeah.
I'm going to see you in 2 years. Her gait would be worse. She'd potentially be in a wheelchair, and so any questions I can answer for you?
No, it's what I expected. Based on her symptomatology, I was expecting surgery to be what she was told. The Dr. Love, I think it was more just hearing from you that you were in agreement. And then my concern already answered, which is the neurological recovery.
Yeah, up to 2 years.
I don't do surgery, I do chemo. And I
Yeah.
forever.
Right.
What to expect, so I know when to tell her, hey, that's normal.
Yeah,
kind of thing.
I think look, we'll be holding her hand through the process and stuff, and so, but I would say that the first 3 to 9 months.